I quite agree.
So we can see what's happened with the. Yeah. You can see the DPR.
Yeah. Okay.
Step by step, yes.
Yeah, you can go. How is because I can. 0.85. So it means that the stenosis is critical.
Yeah, we have not so many doubts about this.
It's functional, but this means that we can try to use a drug-eluting balloon. So the question is, I think we need to treat with a regular balloon before, maybe non-compliant balloon, and then we want to go with the drug-coated balloon. Yeah. Do you agree, Bernardo, on that or not?
I think that we should have, we have a question from Javier while he's getting the microphone. I think, yes, the strategy is totally agreeable.
I think that Javier can, you can call him as to be the chairman with you of the
Javier, come here.
We have this great pleasure.
Javier, please.
Thank you. You know, just to share with you, I think that this patient had several stenosis over the right coronary artery. I think that what we will do in this case will be to perform a pullback to make sure where do you have the big difference in gradient. Because at this point, you rightly know that there is, so to speak, ischemia generating disease in this vessel, but you can really be fooled by angiography in knowing which accounts for the hemodynamic impairment. So my suggestion of what we will do in our place will be performing a longitudinal pullback.
Yeah, Javier, but I have a question yeah, I agree. Okay, I understand, I agree, but I have a question for you. Now we have a big right with the stenosis on the mid of the right. Then we have a PDA, stenosis bifurcation, PDA, at the level of the cracks. Don't you think that can be a good idea without the problem of removing the wire and then putting back on the PDA, just try to treat the mid lesion and then to assess again with the DPR, and then if we are not satisfied, we can do the pullback? This is
I think that
my question for you.
It's a matter of measuring. I think that it's true that it's an inconvenience, but it is a bigger inconvenience to place a stent or to treat the lesion that is not accounting for ischemia. So that's the reason, you know. If for whatever reason you do not have a jump in the cracks, you can be really happy because you will not have to be treating a bifurcation, for example. I don't know which one accounts for hemodynamics. So my impression is that...
No, exactly, but...
Yeah. No, that's
in my mind, I wanted to treat the proximal lesion and then do not touch the cracks. This was my idea.
Sure.
And I would like to treat the proximal part and then doing a functional assessment again, and then in order to avoid to treat the final. But we can do the pullback. So
it will be interesting because if the proximal part is not significant, then you will avoid treating a large segment of the artery that perhaps not needs. So that will be interesting. I think it will be
great. So
very
okay.
Illustrative.
So we can go to see. We can go in fluoroscopy also. I want to pull back. No, I want to see. Wait.
No, I'm commenting this. I think that the suggestion is interesting also because we need to avoid to be too much aggressive here. Here we have just to treat the ischemic lesion.
Stop. You can see we have 0.87, and then we have a jump. So
stop.
I think that it seems quite clear that we need to treat only the proximal part, right?
Yeah, that's very interesting, you see.
Yeah, there's a good news.
Oh, nice. So, Mario, you need to put again the wire, maybe not so distal. And then about the treatment, what's your opinion? We can go with like a non-compliant balloon.
Yeah, 3.0. Use a non-compliant balloon at 3.0.
Or 20.
I would skip at 3.5.
No, non-compliant. We go with the pot balloon. We have a very good balloon, non-compliant balloon. Is a pot by BrosMed that has a very low shoulder, and we will show you. Is great for as a non-compliant and even 15. It's okay. Pot, yeah, and even for post-dilatation of the stent, but we can use as a regular non-compliant balloon.
Roberto, Marco here. I think, especially in view of DCB treatment, using a non-compliant balloon is key. Not oversizing them too much is probably the second key message that we need to bring home. I don't fully get the advantage of POT here. That balloon was proposed to me many times. They never convinced me. So, Roberto, you have your chance to convince me. What would be the advantage of this balloon?
Yeah. Now, the advantage is when you need to post-dilate. It's a very good non-compliant balloon. This is the main concept. Then, when you have, you can have even very short size, short length, and when you go to post-dilate the stent, the shoulder you will see is so small. Then you have you reduce the risk to dilate outside of the stent. Here we don't have the stent, so we use like a classical non-compliant balloon. But I want to show you that is really very good profile for inactive lesion without stent. So I think that I can try to convince you, but so we can go. How is the feeling?
How long is this balloon now?
It's really nice.
So 15. So check.
15.
Pierpaolo.
Okay, it's okay. Inflate.
Okay, we inflate.
Slow inflation.
Slow.
It's a free.
That jumped.
No.
To 10. Save. Fluoro. We deflate. We can go a little bit back. We don't want to have. No. Check.
Buono,
Okay, this can be good. We don't want to have a big, a long dilatation. So this 15 should be,
okay.
so 8, 10, 12.
We'll wait
okay?
10 seconds.
Okay, scopia, fluoro. Okay.
Wait a little bit.
Then we can deflate, right?
Okay.
Check.
Go.
A little bit distal.
Mm-hmm.
So what final person stenosis do you accept in this patient?
We will not evaluate on the final stenosis, probably.
Only
by DPR, yeah.
Yeah, by the
So
physiology.
by the angiography,
Even I will see if we need.
okay, it's not leading you.
By the angiography, I think we can accept any kind of stenosis that are related with the functional assessment, I think. Okay. We can go to see again. We go with the drug coating balloon, so we can remove the balloon, I think.